Bush Newtown is here.
Here.
I'm here. Burnell.
Here.
Vicky is excused. She is out of town. Phyllis. Here. Smitty is excused. She found me on the way over here. Don. Here. Mia.
Hey, hold it.
Angela.
Here.
Matt.
Here.
Kevin Bijou. I don't know if he is officially on leave yet or.
He put in a request. He's been out for the last 3 weeks, but he's trying to finalize it with employee services.
So do we count him as?
He's been out of work. I think Ms. Tasha just needs to officially make it official, but yes, he's on medical leave. Yes, ma'am.
Shannon is on her way. She just texted. And Tanya?
Here.
All right. First item on the agenda is approval of the agenda. Do I have a motion to approve the agenda?
So moved.
Butch?
Second.
Second, Carol. All those in favor?
Aye.
Is anyone opposed? Agenda's approved. Next item is approval of the minutes. Can I have a motion to approve?
I'll move.
Donna?
Second.
Butch, second. All those in favor?
Aye.
Anyone opposed? Next item, discussion regarding the election of 3 committee vacancies. We have 3 vacancies on the committee, and we have an applicant for each of the positions. The first one we have listed. Chris, would you like to introduce your staff before we do that? I didn't know that.
I can. Yes, ma'am. Yes. I thought it would be interesting to get a big picture and listen to items that the insurance committee has as a concern. So I'll start over here to my right. I've got Ms. Candy Toops. She works in our billing portion of the insurance department. I've got Ms. Tamara Reeves right next to her. She works on the operations side. I've got Ms. Keisha Gray in the back, billing. Sandra LeBlanc in the middle, in billing, and Ms. Christina Broussard, billing. I've got Ms. Ashley Wright. She's our retiree specialist. Some of you guys may have already spoken to her. And Ms. Shannon Richard is our secretary. So, yes, I asked staff to be here, so I'm very thankful. Thank you guys for coming.
Thank you very much for taking the time. We appreciate it. All right, first position to be filled is one from the Lafayette Parish Association of Educators, and I'll take them in the order in which I received them. And that position, the applicant is John Downs. Do I have a motion to include John on the committee?
So moved.
Carol moves. Is there a second?
Second.
All those in favor?
Aye.
Opposed? Welcome, John.
Thank you.
Thank you for coming. Again.
And who's, who?
John
But
Downs, LPAE.
Okay.
The next opening, also LPAE, is we're happy to have Ms. Julia Reed, who's the president of LPAE. And I received her application second. So is there a motion to include Julia?
So moved.
Does everybody know Julia? She's sitting on the end. And I'm sorry, John is next to Julia.
I second.
And Shannon seconds, and she's here. Thank you.
Aye.
All those in favor?
Aye.
Anyone opposed? The last applicant is from Apple, and that is Stephanie James. Is she here? She was emailed and texted. So
That's Stephanie. James or Jamie?
James M.
Stephanie James.
Yes.
Okay.
Well, I guess we will hold that over till the next January meeting.
Ms. Vance, does she have to be in attendance? I don't remember them having to be in attendance. Am I misspeaking?
I don't think it's in the bylaw she has to be here, but I don't know.
Because I think you can still vote on it. Am I saying that correctly?
I think
If I remember, if I'm looking in your bylaws, I don't believe that there's any
It's not in the
statement that
bylaws
says they have to be here.
At all.
We voted in the past.
Without them being here.
being present, since they submitted their name.
We have never, since I've been chairman.
No, I was not present. Yeah, the meeting. Phyllis
Oh,
wasn't
you
here.
weren't, so Phyllis is saying she
Correct.
weren't, so I stand corrected. Does anyone know Stephanie James?
No.
Because I have tried to contact her and have been unable to.
What does she represent?
Apple?
She's an active member, Miss Nancy?
Yep, I assume so. That is the one that Deborah Thrower represented so well for so long, and she retired. And she recommended Stephanie James.
So I think if you voted her in, if she said that she wanted to be in, she requested it, and then she changes her mind.
Was it Miss Deborah that made the recommendation, or was it Miss Stephanie who contacted you?
Both.
Both.
This is
Okay.
the email from
Okay.
Stephanie.
Oh, okay.
Trying to see if it,
Well, I move that she be accepted.
okay, Brunel makes
I
the
second
motion. Phyllis seconds. All those in favor? Trish, could you maybe find out where she works?
Yes, ma'am, I can backtrack and find
Because
it.
that way, if she changes her mind, you still have time to go to the board to re-advertise for it before the January meeting.
Okay, and Mia just walked in.
Wait, Mia?
Next item on the agenda is the hub report, Mr. Fontaine, over. And we have some specific items listed this time because they were carryovers, they were things that we discussed at the last meeting that you were gonna get some answers to, and I think Butch has another one he wants to add.
Yeah, one of the ones was the Dexicom that, where we did the diabetic testing with the computer, with the phones and whatnot. We asked you about that. The other thing was, and I was asked about this, because years ago, what happened, we had a situation where people were leaving, like St. Landry Parish, coming over here in their last year. And what was happening is that we were putting them and as well as their family on. And in some situations, like the woman came in fine, everything, but the husband came in with a myriad of just, illnesses, et cetera, et cetera. There's a lot of things. So we had, at one time, we had a schedule that said if someone was coming in for their first year, the school board would pay 10%. And if they were here 2 years or with us for 2 years, it was 20% that was paid out, and the rest of them they had to put in the other. And you had to be vested 10 years before the school board would actually take and bring your spouse in at 100%. So are we still doing
I don't remember
that?
10, Butch. I don't remember being 10 years.
Well, I'm saying it's not. I'm saying 10 years. I'm just saying you're vested after 10 years. That we had done it in increments of 10%. So after 10 years, the school board would pay 100%. And Mona was supposed to take care of that.
Do you remember that, Lynn?
I don't.
And I don't remember 10 years.
Are you referring to vesting, Butch, or are you talking about the
That would not be
Dexicom?
something that,
No,
No.
this is completely separate from the
Okay.
Dexicom. This was, oh geez, this was a lot of years ago. And Mona was supposed to take, and if a person came in, like someone coming in, and wanted to bring the husband on, okay? And it was not a problem, we allowed them on. But if they retired, like after 1 year, then the husband, the school board would pay 10% of the premium, and they would be charged for the 90% for his portion of it. And if he or she came in and put the spouse on and stayed 10 years, then the school board would pay the 100%. Because like right now, for example, someone coming in at the last year of their retirement, coming in for Lafayette Parish School Board and bringing in their spouse, then are we paying 100% of the person and the spouse?
I don't remember the percentages, but I
I don't know,
remember,
percentages are
I
wrong.
remember that you had to be here so many
So many
years.
years, I think it's
You had-
5
yeah.
years. I thought it was 5 years.
Yeah,
No,
You
it-
would be vested.
It was
10
10.
years, but you wouldn't have anybody who would want to come.
And
is the
see, that
point.
is what happened, because we had someone who had 5 years left, and
Yeah.
she wanted to move to Lafayette Parish, remember?
Yes.
Lee
But-
Rayo was the person. And, she didn't come because of that.
But,
We have not had a lot of new spouses, at least in previous meetings.
this is
You made a
about
mention.
vesting.
yeah, it sounds like you're, I thought you were originally starting off with Dexicom, and I was focused
No,
on that,
no.
and then I thought I heard vesting, and then I was double checking to make sure.
Sorry.
I'm sorry, can we, it's not on the agenda.
No, it's not.
We can't have a discussion about it, but we can certainly circle back to it.
We need to
for a
look
discussion.
at
Yeah.
that. We-
All right, well, Trish, we'll hold that for the January meeting. Is that okay, Bush? Just saying. All right, Lynn, do you want to go through the report first, or do you want to address the 3 questions?
I'll address the 2 questions and then we'll go through the reporting, because they're gonna be pretty quick
questions,
as far as addressing the questions. The first one that came up was, with regard to, Dr. Bond and would he be interested in getting into the network? So obviously, the procedures that he does with Regenics, we cover through Blue Cross. We added that to the plan, but it is not something that's in a network situation or anything like this, because there's very few places around the country that do that. We're lucky in that we have him right around the corner here, and folks are utilizing him, and it saves some money, but he's not interested in getting in anybody's network.
I think that was Shannon's question.
Yeah, he was approached.
We approached him, and he's been approached several times. He just no interest in getting in a network.
The Regenics procedure is covered under Blue Cross?
Yeah.
How much?
It depends. There is a schedule of services that he can perform, and depending on the member's medical situation, so let's just say, using this as an example, you have an injection in your shoulder, there's a set fee for that. And that schedule of fees gets updated once a year. It's part of your plan document. And he basically bills out at that fee schedule, and the member benefits apply, deductible, co-insurance, just like it would any other surgery.
Okay, I had a friend of mine who did go ask about it and whatnot, and the cost would have been like $10,000, so they opted not to do that, but it was spine. And eventually had the spinal surgery instead. So, I mean, that's what that was. So I don't know how.
The statistics on that type of procedure have about a 75% success ratio.
Okay.
Okay. And you're going to see some stats in here that show us that it's working.
Okay.
I would be interested to know what the comparison, I know that the Regenics procedure saves the insurance fund quite a bit of money because of hospitalization costs and all that. I would be curious to see a comparison between the Regenics procedure and like a more traditional treatment, like a replacement surgery, to the actual member. What is the comparison?
They're going to be the same because both of the procedures are going to get you to a deductible and co-insurance. So if you've got a maximum out of pocket, your maximum out of pocket. Where the member benefits, okay, so obviously the school system is going to benefit, the plan benefits, from the plan benefits, the members benefit eventually, because it keeps from having to do things like increase rates or change benefits or anything like that. But the real benefit to the member is being able to avoid a surgical procedure, being able to avoid the risk of anesthesia, the risk of infection, and all of those types of things. So from a cost basis to the member, the savings don't really come in the benefits because you can reach your deductible and the co-insurance, and both of them are paid at the same. The benefits come in no downtime from work, less invasive procedure, all of that type of thing. I had my son in an orthopedic physician's office today, 2 years post from a torn labrum, and he's back in there already, and I'm going to see Dr. Bond. Made that decision today.
It also could save the member from having to go to physical therapy and all these therapies. We all know that will cost you an arm and a leg. So if the procedure works and you heal and he slaps a Band-Aid on it and you're good, it'll save the members some money from therapy as well.
Has
The
the
real
procedure
savings
been
to the member
FDA approved
coming.
yet? Has the procedure been FDA approved yet?
I don't think so. Otherwise, it'd be covered under the medical.
You're hearing a lot too on the radio. I don't know if you've heard of a couple of other competitors out there. There's a QC Kinetics, and I'm hearing a lot about and all, and it's all of the same type of procedure. Regenix is the only one in the industry that's been tried and proven long enough to be able to integrate with an insurance plan.
Is it accepted with Medicare?
No, sir.
No, it's not. So then,
It's not up to him.
usually what happens when something's not, if Medicare doesn't accept it for retirees, usually the Blue Cross Blue Shield doesn't either.
No, Blue Cross
They
is
will
not in
cover
their
it?
plan document. We added.
And you have it, okay. All right.
My next issue is the diabetic monitor, the Dexcom.
Right, and we looked into that, and the question from Butch is, do we cover the types of monitors like the Libre and other monitors that are real-time, utilize a smartphone or device and that type of thing? We do. Under the plan, it has to be medically necessary, and it does require pre-authorization. So a lot of times you'll hear folks in the Medicare Advantage side say, oh, we cover them over here, and then folks on the active side say that they're not covered. There's really not a difference there, but obviously when you're in that Medicare Advantage plan, you're hearing more folks with those monitors because they're of the age where the disease is more progressed and they've reached a medical necessity to be able to acquire one. Now, we're also looking at third-party vendors to be able to eventually price with them and look if we can get those monitors at a decent enough cost where we could look to maybe loosen the pre-cert or pre-authorization on that, because you start to deal with convenience versus medical necessity, and what's the hard cost about these types of monitors. It's not necessarily the cost of the device, it's the cost of the ongoing strips and things like that, like $500–600 a month. So the two things that are of major concern, number one, it is covered under the plan, but to get it more readily available, we would have to be able to bring the cost down.
Okay. Well, I had my doctor write a script, brought it to the CVS, and it was turned down. Medicare, there's a certain thing you have to like test at least 5 or 6 times a day, at least medically do that. And then it's a procedure. You have to ask, and then of course, then they'll pay for it. But other than that, and like for me, I only test 1 time a day. I mean, that's basically what it is. I probably should test 2 times a day, but you know, I've been doing one for quite a few years now, and that's why I was asking, because when I started, I can see my numbers coming up, so I know that there's some things that trigger a higher sugar response than other things, and that's basically why I was asking the question, because if I could monitor that, then I'd be better off.
In speaking to several diabetics, everybody would love to have.
I agree.
Because
I
they
totally agree.
can save you in the event. I was talking to a guy who was getting on an airplane. He had an event. He had a monitor like that. He didn't know what to do. You know, it can save you from that. But they're only allowing the monitors to those who have gone through all of that criteria.
So we couldn't get it through, if it would increase compliance for diabetics. And I don't know that it does or it doesn't. It seems to me since it's easier, it would.
He's having a hard time hearing you, that's why I
I
was.
sure did
I
not
can
get
talk
those
about it.
hearing aids. I promise y'all I didn't get.
Will it increase, does it increase compliance diabetic patients? Because it's easier to,
Compliance of diabetic patients, because it's easier to register.
Yes.
Obviously.
My opinion would be yes, only because I'm on with what I've seen. Because in your arm, you press a button and you go. You're not stopping to get something, to stick something. I would personally think yes. From the,
It's so much more convenient, so
Convenience.
yeah, it does increase the compliance because it's, at the snap of a finger, you know what's going on.
Doesn't increasing compliance, wouldn't that ultimately save us money because it prevents complications from diabetes?
There's logic behind that, but right now, because of that cost effectiveness, all of the insurance carriers are using pre-authorizations because they're just not gonna allow a monitor like that for every diabetic out there.
Well, what is the actual cost? The meter is one thing, but then, once that's paid for, it's
Here
the
in the-
supplies
The
that.
monthly cost of maintenance is about $500-600.
It is fine? I thought it was more like around $75 or $80. I'm way under.
It depends on the actual monitor, and then each of those require a new transmitter each year. And look, I'm not a diabetic by any means, but we did research it. You know, you have your monitor, you have your transmitter, then you have your supplies
Right.
that come every month. So the ongoing costs for those particular monitors tend to be higher, which is why they won't just hand them to everyone. You have to meet medical necessity and certain prior authorization requirements. They are covered under the medical plan, they're covered under Blue Cross if you meet policy guidelines to get that actual kind of monitor.
Is there any way we can get the guidelines? Or,
Yeah, it's about that thin.
That's probably.
what a surprise.
I'm gonna be honest, I have it.
I knew you were gonna ask that
Oh, my.
All right, Lance, your questions
you.
answered, but
too. We're gonna continue, to work on that because we're gonna talk to a couple of the different monitor vendors. There are sometimes you can, work directly with them and cut a deal as a
I
margin
think
part.
that's what I had in mind, because when we had the lady from New Orleans come in, because she was gonna put everybody on, the diabetics on it, okay? And she had worked out, and how she worked that out, I have no idea.
The only difficulty in when you
I know
take
she
it
did.
from Blue Cross and go direct to a vendor is to integrate it back into Blue
Yes.
Cross, because somebody's gotta make a decision of who is gonna get approved and declined in the pre-authorization process and all of the other things to adjudicate that.
Right. I appreciate the time that y'all took for that, because it's been in my mind for quite a couple of years now, and,
Well, diabetes is on the forefront of every plan, because when you start looking at the prescription drugs, it's gonna be number one and number two as far as you spend, so.
the new injections are expensive as hell.
okay, Linda, we can go to the report if nobody has any more questions.
All right, so this will be reporting for third quarter through the month of September here. Everybody should have a packet. I have, so you can see on the summary on page 1 that our total participation currently is at 5,756. That is up about 1%, 1.1. Medical claims at the 22,735,000, 17,520,000. The prescription drugs, our total claims through 9 months here at 40,256,554. So claims are a little down, but what's really up and helping with the plan savings is our plan reimbursements, and you can see through 9 months we are at 8,084,781, and last year was 7,641,000. The year before 5,006,000. It's really last year when these reimbursements really started climbing for us with all of the work we did on the prescription drug program. So you see the 8,084,000. Now, what is included in that 8,084,000 is $1,235,000 from the COVID reimbursement there. But even without that 1,235,000, we're almost 20%, we're at 19% increase on our reimbursement. So doing real well there. You can see that we're already at 9 months, surpassed last year with our retiree drug subsidy, so that's a nice increase there, giving us a net payment of $40,256 minus the $8,084,000 and $1,437,000. Our net claims of $30,734,000. Fixed cost at $3,010,594, and adding the retiree Humana cost to that of $473,499. A total plan cost of $34,218,166. Averaging that comes out to $661 per employee per month, which represents an 11.7% decrease from last year. This is the lowest plan cost we've reported to you since 2013, but I will tell you, of late, we've had some pretty high claims runs in the last few weeks here, high cost claimants and things like that, but plan operating pretty well right now. Funding wise, we're talking about funding of $37,869,102. Funding's actually down just a bit. We all know that our rates haven't changed, but demographically, we are every year becoming more singles than families. That takes the funding down a little bit, but it's also good for claims. At the same time, when folks migrate from enhanced to basic to Blue Saver, that kind of thing, lower contributions there. So it's just demographics and plan migration that affected the funding a little bit. You see this more clearly on the next page because we use the per employee per month number to give a more accurate comparison. So participation, we already stated, that's up 1.1%. Your medical claims are down 9.8%. Your prescription drug claims are up 4.1%. But after rebates and discounts, okay, so the gross costs of a prescription drugs are up 4%. That would be phenomenal, okay? Because drugs are going up 12-15% a year. Okay, if we held them to 4, we'd be doing well, and we're doing even better than that because the rebates that we're getting and the discounts bring it to a net decrease of 8.4%. So doing quite well there. Total claims at 811, obviously down some 4.3%. Reimbursements up 40.5%. Now, that statistic's high because you've got that 1.2 million in there from COVID. Even without 1,235,000, your reimbursements are up 19%. Okay? Huge. On your retiree drug subsidies, that's also up, and that's up 45% from 20 to 29. Net claims paid, down 12.9%. Fixed costs, pretty much equal, 60 versus 61. 11.8% decrease on the total Blue Cross plan. Remember, we had a small decrease on the Humana rates last year. That's down 1.8. Total plan cost, again, down 1.7. Funding actually down about 2%. And once again, that's not because we've had a rate change. It's just because we've changed a little bit demographically for that average, and then folks migrating to a lower cost plan, which is a good thing for us from a cost standpoint. So net employer costs down some 15.4%, and then of course we're looking at a surplus there. So some of the best figures we've looked at in quite some time, but we also, and I've said this in previous meetings, we're going to see some high cost claimants because anytime you go through a period of time and nobody gets screened and things like that, or they're not going for their periodic visits, we're seeing an uptick on all of our plans with regard to cancer and circulatory. On page 3, it just shows this to you on a monthly basis, and you can see all of that red when we actually get these rebates and subsidies, a little bit of specific reinsurance reimbursement in the first part of the year, and then that COVID claim reimbursement coming in February. On the fiscal year on an accrual basis, okay, all of the rebates and all of that get taken in the prior year because those are when those claims are incurred. So my reporting that I just went over with you is on a paid basis. What does paid basis mean? When it was received, okay? So we get the claims run every Monday, okay? We release funds for that, so this is all reported on when that payment is made or when that reimbursement is received. The fiscal reporting is on an incurred basis, so the claim is reported when it was incurred, and the rebates and reimbursements track when that claim was incurred as well. So if you look at page 6, you can see that the fiscal year ending in June 30th, $2.7 million surplus, and we're finishing the accounting work and very close to accounting's numbers and all of that, so that's tied into their reporting as well.
So the fiscal report too is unaudited and not officially finalized, so that end number will fluctuate as accruals come in. So I'll be working with accounting to finalize until it's final. So, you know, depending on when the numbers come in, that number fluctuates. So when we did this report, we were at 2.7 million. Now we're actually at about 2,583,000. So just keep that in mind, that the next time we report, this report is probably gonna change a little bit.
Something else, the auditors will book an estimate of what they think is unclaimed, because even though we're paying now, we're still getting June claims after the books close. So they do an estimate based on history on what those claims would be on people that haven't processed claims yet, or we haven't paid those claims yet, that go past September cutoff. So every year they do an estimate, and then, so that'll hit this also as per an accrual basis.
Enrollment on page 7, and once again, not much to speak of there, but I can tell you it's all mostly single in that your employee-only number went up about 2%, whereas employee with dependents or employee and family, less than 1%, only 0.6. All of that is good for the plan because if a spouse has access to coverage where he or she works, certainly would want them to participate with their employer. Enrollment by plan on page 8, slightly down as far as enhanced goes. Just slightly up, a little less than 1% on the basic, and then the Blue Saver had about a 2% increase there. So pretty much what we've seen in the past. Right after the pandemic, we had a little movement to the enhanced plan, but that's come back. From a medical claim standpoint, showing the 9.8% decrease there. All of these bullets at the bottom, what it does tell us is that utilization for small services, $5,000 to $10,000, that went up a little bit. The big decrease, the bulk of the decrease is between $10,000 and $200,000, those mid-range claims, and especially between $100,000 and $200,000, where we declined by about $1,556,000. Okay? On jumbo claims over $200,000, we're actually increased there, but we've got $130,000 of it back in reinsurance. So from a medical claim standpoint, doing well, a 23.4% decrease on inpatient utilization, 10.7 outpatient. Prescription drugs, once again, up 4.1%, but with the rebates and discounts, our net cost is actually down 8.3. We did this while we're having a pretty significant increase on our high-cost meds, which I'll get to. Blood thinners, diabetes medications, chemo, anti-inflammatories. That's what's really driving that particular cost, and I'll review that with you in a couple of pages. So from a total claims perspective, down 4.3%. From a net claims perspective, down 12.9%, which is the more important number, and that's because our reimbursements came up so much. When we take a look at the three plans individually, it's those bottom three bullets that we concentrate on. So the enhanced plan has 15% of your participation and almost 22% of your claims. So obviously, still not supporting itself. Basic plan is coming closer to breaking even. 62.2 of the participation, 64.3 of your claims, so coming close to breaking even. And then, of course, Blue Saver is helping to support the total plan with 22.7 or close to 23% of the participation, but only 14% of the claims. Total plan cost, once again, down that 11.7%. Net of employee contributions down 15.4, and I've got a note down here, lowest since 2013. But keep in mind that we've had some pretty high weeks lately. Claims by type of service are inpatient down 23%, outpatient down 10.7%. Still have a decent amount of utilization that, from a professional standpoint, professional encompasses all of your provider visits and things like diagnostic testing and such. So still decent amount of utilization on that. Top diagnosis, and when we were having conversation about Regenix, I'm just going to, it's really hard to quantify, but if you look at 2017, musculoskeletal is number 1, 2018, number 2, 2019, number 1, 2020, number 4, 21, and now you see musculoskeletal on the decline, and then when we look at it on a per employee per month number, 2019 was at 26, we went to 15, and we are currently at 9. Then further on in the reporting, and I'll take you to that right now just to show you, if you look at page 25, you'll see that we went from 97.3% network utilization to 96.9%. That worries me, okay? So I dug into the details. Guess who it is? Ms. Money. $275,746 so far this year. You'll also notice that, what's down is circulatory, musculoskeletal, injury and poisoning, digestive, respiratory. What's up is neoplasm, which is cancer, infection, and pregnancy and childbirth. Pretty much exactly what you would think it would be. On an outpatient basis, factors influencing health include chemotherapy. That's why it's number 1. Circulatory almost equal from last year. Jump in neoplasm and musculoskeletal on an outpatient basis, and all of the other categories going down. Last time we talked, it was the only time I think I've ever reported to you where Lourdes was the number 1 facility on this report. But that's corrected itself, and Lafayette General is back at number 1 here. you'll see MD Anderson in there, which is indicative of some increased cancer. Up to 87% on our generic utilization. Part of that's attributable that we don't have a vaccine involved in the plan as much as we did in the past. At the same time, even though we went up 2%, we're actually down 1% on, so first page tells you the number of scripts, second page tracks the money. So first page tells us that, or page 19 tells us that 13% of our prescriptions are brand name. Page 20% says that 13% drives 86% of your costs. Big difference between generic and brand. Slightly lower utilization. That's predominantly coming off of the pandemic. On page 22, as far as my school systems, you get the prize for being the most sane. Okay, why? Because everybody else is riddled with depression medication, anxiety medication, a lot of that. And I'm not saying just a little bit, things like 4 out of the 10. Okay, you have one down at the bottom, but you don't have an ADHD medication on here. Usually I see 2 of them. Much better. So it tells you how sane everybody is over there. Okay. Lower utilization there, and that's a good thing. We also did some education and constantly talk about the EAP, which has probably helped those numbers as well. So if somebody's talking to an EAP counselor versus taking a med, that's a home run, folks, all day long. Top 10 by dollar amount. And once again, let me point you to the first bullet. This is 6.5% of the number of scripts that drives half of the cost. So less than 7% of your prescriptions are driving basically 50% of the money. What's went up? So Eliquis went from $14 per employee per month to $32. Trulicity, on down the line. So blood thinners increased 113%. Diabetes, 210. Cancer, 87.5. Anti-inflammatories, 24.2. Now you don't see the on here, that is for the polyneuropathy, but it was number 11, but it's over your specific reinsurance. We're actually getting reimbursement on that. So pretty handsome increase on these high cost meds.
I have a question. Medicare has now looked at prescriptions, and I'm going to say they're going to buy, they're going to offer a bulk, if that's the right terminology. Is that going to help our prescription with driving the costs down? Because Medicare is now going to set the price on certain medications.
The government's talking about price capping there in Medicare. All of that has not been finalized yet. Would it bring the cost of pharmaceutical care down? If we cap the cost of drugs, obviously it would. That's going to be an interesting one to watch. I'll watch that because, there's a lot of power in Washington from Big Pharma. It's going to be a fun fight to watch. Like, beat Foreman and Muhammad Ali or something like that. A lot of money behind all of that. There's so many things out there. I was meeting with some medical providers yesterday on their plan, and doctors at the table talking about all of that. Some of them of the camp of going back to these tried and true older medications that work, that don't have all of these side effects. And the other camp of all of the new, but the new has some pretty significant cost to it. Side effects and things like this.
But would the old medication cost more because doctors aren't prescribing them.
The
So
old
would their driver cost
medications
up?
cost less. It's all of the
Okay.
new meds that are coming out that cost so much more,
Can
especially with regard
can I
to
make just a
diabetes.
statement? Just recently, cholesterol is a problem with me, so I take a statin. I was on private statin, and I was using my local pharmacy, and when I went, the cost was zero, okay, because apparently our insurance, Blue Cross Blue Shield apparently, along with Medicare, that's the golden boy supposedly. I had to get a new lipid profile, and they changed it to Avorstatin. And so I had it done at the local pharmacy, and it was $30 copay. Okay, that's for a 90-day script. So they called back and said, this stuff is working. I said, okay. So what I did was I said, give me a script for 180 days. Okay, and I went to GoodRx. And for this was 90 pills for $30. And going to GoodRx, and there's several of them, by the way, and I've said this before in here, and I'm sort of repeating myself, but this just happened a week ago. And I got 180 pills, which is a 6-month supply, for $16.81. So if we as a consumer shop around with the old med, and it's an old med, I mean, and metformin is another one that I take. It's an old med and it's cheap. But if you use, now the only problem I have with that is that, and I can understand this, Scott has some local pharmacy. We have some people that are coming in, but then the big boxes are the ones that usually do the GoodRx and the others and whatnot. But I paid $60, okay, for 180 pills, and I got it for $16. So it's my savings, and that can happen to any one of us, is what I'm saying. So, and that's it. I have the paperwork to prove it. It's just that sort of thing. So, I don't know if we should try to get this to our retirees and just, hey, look, you could do this if you're interested. And believe it or not, going through the listing of it, I think CVS came out with 180 was $135 or something. That was without the insurance. No, that was just simply the bills coming out of them, that way. But it's something to look at, is what I'm saying.
You're promoting consumerism not only on the drug end, but on the provider side as well.
Yeah.
It pays to shop, and there's no difference in, let's say, an MRI or a diagnostic procedure. Do not think that just because you are a provider in the Blue Cross network that every provider that can do an MRI within the 50-mile radius around here charges the same price. It's like night and day. Some of them charge double with the other one.
Appaloosa is one of the cheaper ones for the MRI.
Consumerism can go a long way, and constantly on that education.
So if you're scheduled for a scan that requires authorization and Blue Cross approves the authorization, it may have happened to someone in this room. Blue Cross will reach out to you and let you know, hey, we got your approval. Not sure where you're having it, but based on your location, this is the lowest cost provider in your
Really?
area. Yeah, it happened to me personally. It happened. So if you get that call, what they're trying to do is save the plan money and save you money. Because they're going to drive you to the lower cost network provider, and it's going to cost you less out of pocket. And all you got to do is call your doctor and say, move my order. And in fact, if you tell them, help me, that person that called you will help you move your order.
Really?
Yeah.
Wow.
So part of what Blue Cross does in their fixed costs, besides just processing a claim, they do provide utilization review, case management. Those are functions like that. So it could be something as simple as that versus a case manager reaching out and making certain that somebody with a transplant goes to a center of excellence and all of that type of thing. So they're steering you to the lowest cost provider.
Cool.
Page 24, PPO savings, still running at a high at 69.8% here. We've stayed high in the last several years here. The reason why we remained with Blue Cross is predominantly because of that high discount. They have the largest market share in the state, so they have the deepest discounts from a provider standpoint. Once again, 96.9 or 97, and all the reason why it's not almost 99 point something is because of Dr. Bond. And then from a fixed cost breakdown on page 26, we are still operating this plan for less than 10%, and the only reason the percentage went up, remember the first page, our fixed costs are equal. Okay, so fixed costs did not go up. The only reason why the percentage went up is because the claims went down. Okay, so our fixed costs remain very, very low. We're operating our plan for a lower percentage than Medicare. The federal government operates Medicare for much less, and then you'll have questions from time to time from different folks or constituents and whatnot. Why are we self-funded? Why are we going direct to Blue Cross and just buy a plan? Okay. Number one, you would lose your entire control over the plan. Okay. And number two, because we're able to negotiate a better cost to operate the plan and have much more flexibility in doing so. Next page, contribution analysis. Once again, we did not change any rates, but with the more singles and some migration to the lower plans, funding's come down just a little bit, but the contributions, the cost net of contributions down some 15%. Page 28, just a duplication of some of the medical claims expense to show you where that what went down, what went up. The bulk of what's gone down obviously is between 10 and 50,000 there, and then of course the 100 to 200,000 that we saw. Big dip in claims there. And then last but not least, just the summary considerations on the back if you want to refer to the talking points of this quote.
Anybody have any more questions for Lynn Fontaine? Or for Brooke? We appreciate you both being here.
Thank you very much.
Any
You guys
questions?
have been really good.
Thank y'all.
Next item on the agenda, and for John and Julia, if it's a lot of numbers and a lot of information, it gets better as you go along. Next item on the agenda, bylaw report. Phyllis?
Yes, I'm happy to say that we're trudging along here, we're making some good progress. We do have some suggestions that we're still working on, so we should be more than likely done by early January.
Okay, thank you. And January, Carol, yes, ma'am.
I have a question. And I'm sure this is going to be a question for every organization as part of this committee. When we have, hopefully we'll never have another pandemic,
Hopefully.
but if we do, we need to decide how we're going to be communicating with our employees. Because I got a call and it said to me that the retirees would be kicked off the insurance committee because we weren't meeting during the pandemic. And that alarmed me. And maybe you were meeting during the pandemic, we weren't, but we were sharing information through Facebook, we were sharing it through email. So I'm just concerned, what are the guidelines? What are we going to do for everybody in the event that we can't meet?
What we did during the pandemic, and we met through the pandemic, unless I'm dreaming, we had a lot of Zoom meetings.
Not us. I'm talking about retirees, like our group. Our group could not meet during the pandemic, but we shared information. But we were told that we would be off this committee because we weren't having any meetings. So that should be for everybody, that's just not for one group within the committee.
Right, I think the concern was that whether or not that organization still existed because there had not been a meeting.
But that should be for everybody, that should be for LPAE, it should be for,
But Carol, I think part of the problem was the lack of meetings started before the pandemic. Your president became ill, and there was no vice president. There was a secretary treasurer maybe,
Secretary who passed away.
and there were no dues collected. And so it came into question, some people questioned, does the organization really exist if they have not collected dues, if they have not, and I understand your point.
Yeah,
I mean, I
because
think the
at-large
last thing.
people, what do you do with the at-large people? Are they paying dues? That's my question.
No.
Are they
The
meeting
organization is.
regularly? Do they have a president? That's
I
just a
understand.
question.
And I don't
It should
think
be
any-
for the whole, not just for a particular portion of the whole.
Miss Nancy, I think I'm confused. I don't know that that's an agenda item
It
this
is not.
evening. Okay,
Well, it's part of the bylaws. And
okay.
But I
it's
think
included in
that
the
committee
bylaws.
that you're talking about is not the insurance committee, because there's
No.
no dues or
No.
anything to be
No.
paid. The insurance committee will meet via Zoom as they did.
Right.
Yeah.
Whatever happened there, that has nothing to do with these bylaws.
Nothing
Right,
at
it
all.
wouldn't
You're
fit
right.
into our bylaws, we wouldn't address each individual group as far
Correct.
as how they're gonna be.
That you're representing, I see what you're saying, the group you're
Yes.
representing. That has to be addressed with the group the other group, not this.
But we were told that we would no longer be part of this committee. So that's part of the bylaws. If you're gonna put in the bylaws, that if you're not, whatever the guidelines are, that you're not gonna be a participant anymore, that needs to be put in. And it should be for the whole, not just a portion of the whole.
Well,
That's what I'm saying.
I think, Carol, if, let's say, for whatever reason, an organization no longer existed, that could be in the bylaws that, and this group would vote that if we still want representation, I think the greater the representation, the better for all of us. Because the word gets out more, the more groups that are represented here. We would amend the bylaws at that time, if it happened, and make people all at-large representatives, which we could do.
Yes.
But
That's
I
my
don't think
point.
there's
That's
any
my-
reason to do it now.
That's the point I'm trying to make.
Right.
Okay, I'm done.
Okay, next item on the agenda.
Miss Phyllis, I have a quick question if you don't mind. Just a reminder, administration would like to look at the bylaws to remind me we're bringing them back in January for a vote?
Yes, it's in the
Correct, the
bylaws.
superintendent would like to review them prior to approval. So are we working, remind me, I'm trying to remember, you had noted to have the bylaws ready for review 10 days
They have
prior?
to, this committee,
Okay.
anyone who's voting on the
Okay.
bylaws have to have them 10 days before the vote. We haven't set the January meeting yet, but the bylaws would have to be distributed at least 10 days prior to, that's Robert's rule. So
Okay.
I don't know if it's in the bylaws or not, but it is in Robert's rules.
So then, I was just wanting to make a statement that, yes ma'am, superintendent would like to review bylaws at the time, yes ma'am.
Okay, thanks.
All right, next item on the agenda, group health insurance premium schedule review. Trish set it out, and this issue came up because of an employee. I don't want to go into specifics. But the question I have is, are we being clear as far as the cost is concerned? For example, if we have a retiree and somebody, and a person on Medicare, and that person on Medicare is still working, and he works where there is insurance, but he doesn't have that insurance, should we put on our document somewhere that Medicare regulations may change this schedule, may alter this schedule? Because I think that's happened to people, and it's a Medicare issue, but they're looking just at this schedule.
So we can certainly add a footnote. I have gotten authorization. We can add a little bit of clarity. I can designate something at the bottom. But we do have those conversations with members. We do remind them that they must be Medicare primary, not working in any capacity whatsoever, full-time, part-time, contract, any type of capacity in order to receive the discounted rate, because coordination of benefits is based on that rate. When the member gets a reduction, oftentimes they're receiving a reduction because they're likely on the enhanced or the basic plan. If they're on the high deductible, then you're gonna see an increase in that example. But they oftentimes see a reduction because Medicare's picking up roughly 80% of those claims in billing. So that's the reason for the reduction.
Right.
Whereas as long as it's an accepted Medicare service, Medicare pays primary, Blue Cross pays secondary, picking up the remainder. So therefore, LPSS reduces that premium because our liability is not as much.
Right.
But we do have those conversations when that member, we're in the process of revising a few processes to make sure that the member is aware, to make sure that we're communicating that information when we talk to the member. When they come into insurance and they give us our Medicare card, we do have conversations like that. We've developed a small handbook that kind of gives a little bit of information with regard to it, with regard to the changeover, how coordination will go, and why they're receiving the discount, what those premiums will be. But that's certainly doable. But with that being said, we are implementing a few new processes. We're working with Blue Cross on obtaining a few new reports that would help us ensure that the member's coordination of benefits is running correctly. Because we don't want the member to pay the reduced premium, and instead, we're paying the shoulder of those claims and billing because the member's working.
Right.
Then you've got a funding issue.
And what
We're not
can-
receiving enough funds, yet we're paying a majority of the claims and billing.
And what can happen is, you retire, you're not working, and X applies, X premium applies, and 4 years later, you're working,
Correct.
and you haven't contacted the school board. So I think just so everyone is in a position where they understand this document, because I think that you're aware of the problem that I'm talking about. If someone just looks at this, they think this is the amount I should be paying, but I'm really paying something else. Why is that happening? And I think if we just add that Medicare regulations can alter the amount you pay, check with the insurance department, maybe it'll be a reminder to people that they don't just look at this and think.
Would a simple reminder, just if you go back to work, any retiree who simply goes back to work, make sure you check with the insurance department to make sure that you're scheduled in the right component.
And we are gonna start developing.
I think that's the easiest thing to do. Don't make it complicated because, like she said, you retire and maybe 4 years later you're gone. You're not thinking about the deductions and everything else. You really aren't. You're going by what you saw in your paycheck that comes in every month. And so you don't know, but the
Or
thing
you look at
is,
this schedule, and the schedule isn't accurate for what you're thinking you
yeah,
should be
that's
paying.
correct, yeah.
So I think we can avoid some problems, which would be nice if we just said that, however you want to phrase it, that Medicare regulations can change the cost or the premium. And
Because the key to that too is they must maintain Medicare eligibility. So if the member, let's say the member doesn't pay their Medicare Part B, that reflects it too, because then the discount is applied for members under Medicare A and B.
And
So
you
there's got a lot of
understand-
factors involved in it.
you and all your wonderful department understand all that, but the average person
Right,
who's
they
going
don't.
into your office to retire has no clue.
Right.
And 5 years after they've been out of the system, they really have no clue. So having somebody go in and look online and see a schedule and say, oh, that's what I should be paying, when that's really not what they should be paying.
We can certainly add a footnote. I have a general idea of what I'd like to apply, short and simple. And we're going to revamp some processes. Once we have our additional conversations with Blue Cross, we nail down a few more things. Those attestations will be mandatory for any member turning in a Medicare card moving forward, to include member or spouse. We're going to work through that process. We may need additional information from the employer if they are working. That tells us whether they have health insurance with that employer too, because that has an effect on who pays primary, secondary, and so forth. We are working towards annual attestations too, so that it's a friendly reminder, hey, if you do have a change in work status, we do need to know notified, and Medicare also needs to be aware of it too.
But not only that, not only the school board retiree, but the spouse also.
Right, yes, we would
See,
work
that-
on developing.
I mean, I was just thinking of just the
Yeah.
retiree, then when you're bringing it up, but it also affects the spouse.
It does, yes.
Absolutely.
That is a,
So
both
we're
member, any
talking,
member that's under Medicare.
if
does affect them.
anyone on the school board, or, school board insurance, if either the retiree or the spouse has a change in employment, they need to talk to y'all.
Correct, and then what
That's
we
as
may
simple as
do,
it gets.
yes, when they contact us,
Uh-huh.
then we will assist them, because Medicare also needs to know.
Oh, yeah.
Medicare is not aware of return to work status either. There's always a lag. You know that there's a
But then
lag.
they're gonna be
Yeah.
reported on from probably the employer, and that could create a problem with monies.
There's a Medicare coordination number, an 855 number, that we can assist them, that the member can call if they have returned to work.
Right,
And due to that lag, it hasn't quite caught up to Medicare
Right.
yet, to where they can report directly and say, hey, I've decided to return to work. I wanted to make sure that you know that I'm no longer running Medicare primary. I'm gonna be running my
Right.
employer primary in Medicare secondary. And then Medicare will work through their issues, and then it will eventually update. You know, there's always a lag with everything, but,
And we now have that communication system that we
Right,
spend a lot of money for.
yes,
And
ma'am.
I think that, just like what we're gonna talk about later, that's something we can use to advise
Definitely.
retirees, maybe quarterly.
Yeah.
You could send that information out. Since now you have the ability to do it without
it's-
taking a whole lot of time.
It's been a wonderful resource. Yes, ma'am.
Next item on the agenda, discussion interaction regarding the next meeting. Our next meeting is generally January, if everybody wants to check their calendars.
So Ms. Nancy, Hub did leave me with a date, either the 24th or 31st is what they had available to where they could provide
Of January?
reporting for you. Yes, ma'am.
So is the 24th of January acceptable? Does anyone have a problem with that date? Well, let's make it January 24th, and if we have to move it, but just like this meeting, I'll send out an email, Trish sends out an email, then Ms. Dorothy sends out the agenda. So everyone's reminded at least 3 times. The January meeting is important because we'll adopt bylaws and elect officers. Chair report, the only report I have is the next meeting. I would ask Trish if she could, if it's not a problem, to post, I was asked this, if you could post somewhere on the website, the insurance budget. I think it's page 250 and 251 or something like that in the budget. If you could put that on the website under insurance department.
It is listed on the approved board doc budget. Is it doable to where we could put
Yeah.
it on the website?
Yeah, instead of having somebody look through the whole budget to try to
We just
find
put a
the
link to
insurance.
it, budget, insurance budget, and a link to the,
Yeah,
to the.
however you do it. Because someone was looking for the insurance budget and had to look through the whole thing and gave me the page numbers.
Okay.
Another thing we were talking about before the meeting, and Trish and I had spoken about it earlier, is reminding all the retirees, this is anybody who's active, anybody you know who's retired from the school system, there's so many TV ads about joining this Advantage program, you can get dental, you can get vision. Anyone who leaves our Medicare program and Silver Scripts, either of those, risk losing all of their LPSS benefits. It's very important that people know about it, and I think it's important not just at this time when it's open enrollment, so to speak, but I think that's something else that quarterly we should be seeing, that
Yes.
you cannot
Yes.
leave
Yes.
Medicare and Silver Scripts,
Yes.
because we did get to everybody and say, you can't get out of Medicare. Then this week, we got the Silver Scripts brochure, and it says biggest day, do you want to change?
Yes.
And you think you can change, and the statement that says if you change, you lose all your benefits, is the last sentence on the page. that keep locked in the city. So it's extremely important, I think, that we spread the word and help Trish get the word out. And I think that,
I have
yes,
a question on the Medicare, these calls that never stop.
You're right.
About the Medicare, and then they talk to you about getting a test of some type at the end, and they let your doctor know. Have y'all been getting those?
yeah, I've got the call.
But one of the things
Just
that they're
say no.
coming through with, and they're pushing,
You're not old enough.
I know.
it's the Medicare Part D.
Yeah.
It's
Yeah,
the
prescription.
scripts, and
It's
that's where you get, you go with this other company, then you get the
Yeah.
glasses, you get the hearing
Yeah.
aids, you get
No,
the
no, but I'm
teeth.
talking about this, it's a continuous, I mean, it's like a test that they'll give you, it's a test that,
But no, you listening too long, you ain't.
I haven't gotten one of those.
you got one too.
And then I block it. See, I've been but Trish, somebody called me today for the prescription, and I said, "Do you like Blue Cross?" Yes. Do you like Medicare that you have? Yes. I said, "Leave it alone, because if you touch it, you might touch the wrong thing and you're out." Now, again, y'all, I'm going to tell you, retirees have been calling me because they're getting the email about we need your Social Security. They're trashing it because they don't know if it's real.
Okay,
So
I can
just to
send
let
out
you
a message
know,
on that one.
maybe if you send a postcard saying this is legit, because you're not getting a whole bunch, because they're calling me, and I'm saying, I didn't respond because I don't know if it's real neither.
I didn't get an email about a social
Oh, yeah.
security number.
No, okay, so we have a few. We're doing an audit of sorts too. The old Social Security cards had the social numbers
The
listed
real
on them.
one.
We obviously scan that one to the records, but the new ones have a new letter /
Yes,
digits
yes.
numbers. The billing department is working on a Medicare audit right now, so they have sent out a few emails. It's coming from Miss Sandra, and it's got Miss Candy Toops' name on it too. So they are legit, but I'll be more than willing to send out, we can narrow it down perhaps to those members and maybe send out a Blackboard message specifically to
Yeah, I
them.
would send
Something,
my
'cause,
number.
Yeah.
Well, I got
Some of
one,
those,
and I
some of
trashed
those
it.
some of those are, they work it to where they can record you saying yes, and then they use that for other things. It's a dangerous thing.
Okay. Well, I'll put the Social Security information on a Blackboard. Miss Ashley is the one who's been heading up corresponding with retirees. And then I know Miss Nancy had asked me to just send a friendly reminder with regard to silver scripts. In our last communications, we did ask them Medicare Advantage Plan, Medicare Supplement, and Medicare Part D, which essentially would be silver scripts, but we'll just reemphasize the name silver scripts and send out a short communication on that too. That's doable.
Thank you very much. And last item on the agenda, second to last item on the agenda, rather. Trish, your report?
Okay, Miss Nancy had asked me to touch on a few items. She wanted a report on open enrollment, the retiree communications, the Blackboard system that we just spoke of, and contracts. So open enrollment's going great. We're at the tail end of it. We've got about 11 district locations still to go through with regard to EBI is now going out to every single district location. The employees are excited that they're back on property. They really haven't seen them in 2 years due to COVID. You know, it helps when you're one-on-one with that individual versus via a Zoom or via a telephone, and where you can ask your personal questions and rely on the person that's sitting across from you and get a good answer. So we are heading up the tail end of it. We have sent out tons of communications reminding members, hey, we're nearing the end. We're about 3 weeks out. November 11th at 4:30 is the last deadline for open enrollment. So that means any voluntary benefit changes or group health insurance. Group health insurance is done here at central office with LPSB insurance. That's the staff that's here tonight. So if you need health insurance changes, contact us here at Central. Educational benefits has already gone to a majority of the district locations. However, there's still 11 more, and they're also wrapping up central office. The last week, anybody can come to central office. I'm gonna send out a communication. We do have the boardroom reserved. We have an instructional conference room reserved due to the boardroom not being available. And I also have Title I's, but I'll make sure that employees know that they can come to central office, they can still speak with EBI, and they can make those voluntary benefit changes. It's super important for those members that have flexible spending accounts, dependent or medical, because if they do not renew them, then those benefits drop. So I've got EBI sending out 2 communications with regard to flexible spending, specifically with the members who have flexible spending who have still not renewed. So they're putting hands in communicating with them directly. But I will send out, I've got one more district email in addition to our public information officer is going to send out a text or in J-call message to our active members just to remind them so they do not miss their open enrollment. Because if they miss it, it's not till next year or a qualifying event in order to make changes. So if you have any questions, please reach out to staff and we'll point you in the right direction. Retiree communications, the Blackboard system's been working out great. I think it was an initial, oh no, what is this? And someone said, I know that you helped clear the air with a lot of them, Miss Katie, so thank you, appreciate
On
it.
Facebook, it's saying, is this
yeah.
legit?
Is this legit?
Yeah.
But I think once we got through that first hump,
I agree, I think everybody
I
was
think
relieved.
it's going well. Miss
I do too.
Ashley has been putting together some
I agree.
communications. At the minimum, we want to send at least one a month. I would prefer to send 2, especially if they're pertinent specific. Like we've got the wellness, December 7th, call in to Blue Cross coming up that Ms. Tamara heads the wellness incentive, and she wanted to make sure that we got with Ms. Ashley so that Ashley can send out the Blackboard communications with regard to that. So we've got that. We've got the 2 reminders that Ms. Nancy just asked me to send out. I'll work with Ashley. We'll make sure that those communications go out. I think it's wonderful. I'm very excited. I like the fact that if we have a communication that has to go out, it's not snail mail, it's not delayed by 2 or 3 weeks, and we're able to communicate immediately. And for the most part, for those one-off members that just don't understand the communication, then they're contacting Miss Ashley. Ashley is explaining it to them, and we're working it through that way. And if it's too much coming Ashley's way, we're dispersing it to other staff members. That way they can answer questions quickly. But no, I think it's wonderful. Are y'all in agreement?
I think it's
You
a
like
huge
it?
step forward. I mean,
Right.
40% of your plan, at least, is retirees. Having had no way, y'all were having to address postcards and I mean,
Yeah, it was cumbersome.
Most
Yes,
people
ma'am.
have a phone, so.
Right,
And
Now,
you
Just
said,
remember now, there's a population, we
right.
still have slips. And the old fashioned say
It's okay, tell them.
Just remember, you do have that population.
I don't want to brag.
They're older than.
but yeah, I think it's
Oh, my mom is 94, she was just.
I think it's a blessing. I really do. I like the fact that we're able to send it out readily.
Yeah.
And it's super efficient. Miss Ashley, after that
Yes,
first
it
message
is.
that we sent out, Ashley did a double check. Are the phone calls going to the correct members? Are the emails going to the correct members? It sends us a report that tells us those error messages, and then she worked back through them before we sent out the second message, and we got a better response that second go round, if I'm saying that correctly. But no, I'm very excited. I'm glad that we have the opportunity to communicate. It's
I think
helpful
it's gonna
for
pay
you.
for itself.
It's helpful for us.
Communication.
Right, yes, ma'am. And then last but not least is the contracts. There are a total of 4 of them that are currently being discussed. We've got the Blue Cross Blue Shield admin fees. Because we're self-funded, it's mainly just administration fees is what we pay to Blue Cross. We're working through the renewal process with regard to the administration fees. EBI is next on the list, voluntary benefits. Their contract technically ends on 12/31. We too are working through the contract to renew for next year for 2023 for voluntary benefits. HM is your stop loss coverage with regard to Blue Cross Blue Shield. We have reviewed a couple contracts based on HUB's recommendation, and we had BCS last year in 2021, if I'm saying that correct. I had to pause for a second. 2021, we had BCS, and they offered a more favorable rate. But now this year, HM is increasing, so we're reviewing that contract. BCM wants us back, and there will be a slight increase with that contract, about 2%, but HUB too is making a recommendation to go with the stop loss carrier for BCM.
And Blue Cross Blue Shield, going back to that,
Yes, ma'am.
it renews in December.
It renews January 1st of every single year.
There's no sunset,
Not unless,
unless we bring it.
unless we terminate the contract,
So
yeah, bring
I guess my question
termination.
is, there's no contemplation of doing anything with Blue Cross Blue Shield this year, is there?
No, there's not, no ma'am, no. Our Humana contract, we have had discussions with regard to that too. That's our Medicare Advantage option. We have Blue Cross Blue Shield if you have Blue Cross as a secondary and Medicare, and then you have your Humana option, which is your Medicare Advantage plan. They came in with a more favorable renewal, a couple dollars less than LPSS. Takes care of that whole entire premium, where if it's employee only, they pay $0. If it's employee plus spouse, they pay $49. So it was a reduction for our costs on the backside with regard to LPSS. But yes, ma'am, looks like that Humana plan will also be renewed for this year too. And then last but not least is your RX benefits. What they do is they work through a process, that's your prescription services for your PPOs, your enhanced and basic services. They too will likely be renewed. There's no concerns with that contract. They are offering additional discounts effective January 1st that we typically get. Hub is trying to put that information together. But yeah, every single year, those discounts are sweeter and sweeter for LPSS based on.
What's the name of it, you said?
Okay, so it's called RX Benefits.
Archman, okay. That's what I thought you said.
They work for your CVS Caremark. They do the two PPOs, the enhanced and the basic.
That's good. I
Yeah.
thought you said something before, right?
Oh, no, okay,
Okay.
RX Benefits. So yes, ma'am, everything that you see on the list, a total of 5 contracts,
Just
will
one
likely
question
be renewed.
quick. I know that Lafayette General is the top provider for hospitalization, but Lourdes is right behind it. Has there been any talk of renegotiating with Lourdes too, so that maybe they could lower it? And
I know Lynn has been in constant contact back and
because I mean, it's
forth
pretty
with them.
close, you would think Lourdes may want to give us a bigger discount to get more patients. Not that they're looking for.
Okay, I think the last visit, Lourdes was higher than, Lourdes was actually higher last time than Lafayette General. That was one of the first things I looked at this time.
It was, and
was.
Lynn said at that point that he was going to be talking to Lord.
He's in consistent talks when he gets those numbers. I
Okay.
think he almost
'Cause
likes
it's
to
close.
pit them
Maybe,
against
you
each
know,
other,
they're
so you
not-
would give a better
They get those
discount.
little nuts and talk, they negotiate, they pray a lot.
And it may be an either or in terms of contracts. I mean, Lafayette General may say,
Yeah.
I'll certainly double check with them, but yes,
we'll
I
give you a
know he
discount, but
stays
not
on
if you
top
go to
of it.
Lourdes too. You know, so.
Yes,
They
ma'am.
do the line on the doctors.
I think it's enough business for both.
I think so, yeah.
And Hub is an automatic renewal.
Yes, they're evergreen. Technically, they renew in March annually. We do review their contract, but for the most part, unless, just like with any of these other contracts, the majority of them, unless you have written cancellation, they're going to renew. Yes, ma'am.
All right, last item on the agenda, is there a motion to adjourn?
So moved.
Yeah.
Nat and Brooks, move. Donna, pick one as a motion and another one as a second. All those in favor?
Already got it.
Anybody opposed? And we're before 7 again. Thank everybody very much.
Thank you. Hey, Ashley, I wanted to introduce you to Miss Carol.